Yeah, so this procedure will not get a spherical head,
Yes.
but whatever head is that, it allows it to function in a better manner.
When do you consider head reduction surgery?
So I'll
Those are
come to the
late and
salvage procedure. Very quickly, we don't have much time, but very quickly, for sake of completion, and so that also residents can write this in their exam if there is a question on Perthes, are salvage procedures. So what happens if the head is ossified, remodeled, and you end up with a femoral head which is completely irregular? Of course, one of the option could be to do an excision or to do a THR at a later date, but there are 3 salvage procedures which are described, and I'll quickly take you through them. The first of this procedure is a valgus osteotomy. So this was herring C, now healed, has a stiff hip, there is a hinged abduction, and if you do an arthrogram, now we know that there is this bump which is hinging the abduction and making this painful. One way to tackle this would be to remove this bump and add a shelf procedure. Another way is to do the valgus osteotomy. Now this valgus osteotomy, what it does is it puts the good part of the femoral head in contact with the acetabulum, and it removes the bad part of the femoral head away from it. And along with that, it has little other fringe benefits. It improves the neck shaft angle and improves lurch of the child. And these all children have shortening. So whenever you do a valgus osteotomy, you get apparent lengthening of the limb. Varus osteotomy gives rise to shortening, valgus osteotomy gives rise to lengthening. So these are additional benefits. This is another child who also has a irregular femoral head, which is a smaller head, and has restriction of movement. He is not able to really abduct well. And in this patient, we did an MRI, and the aim here was to remove this bump which was causing pain. So that was one problem. The second problem is trochanter is high, and we also wanted to get the trochanter down so that the lurch of the child would improve. So what we did in this child, this is known as relative neck lengthening and osteochondroplasty. Relative neck lengthening is equivalent to transferring of the trochanter distally in a safe manner, and osteochondroplasty is removal of the irregular bump, or also known as bumpectomy in simple terms. So we planned this using an MRI. This surgery is done using a safe surgical dislocation approach, and after the procedure you can see trochanter has come down and the bad part of the femoral head is removed, excised, and this patient improved range of movement and reduced his pain, at least for time being. The third procedure what we do is known as femoral head reduction, and if you see, you have 2 areas of femoral head which are like 2 hills, and the valley is in trouble. So valley in India is also in trouble. Valley in this Perthes is in trouble, and really what politically what we are not doing is excision of this valley and getting better part of the country together. Okay, so what we do in this case is remove the bad part of the head, which is the valley, and the head which is enlarged we reduce in size and convert into a spherical head. Okay, so this is very uncommonly done procedure. I've done very few of them, but this is one of the procedure we did. We removed this part of the head in between, which was irregular. We shortened the femoral head, made it spherical, fix it with screws, and also at the same time, distalize the trochanter. So these were 3 quick procedures. So in a nutshell, in this procedure, I want audience to be with this. You can even click these slides. In a child which is younger than 8-year boy and 7-year girl, if there is any vascularity, any classification, and there is no extrusion, and most of those children you will conserve. Even herring C in a very young child, you will observe, conserve, and see what is happening, and you will operate only if there is extrusion. So younger children with extrusion will require a containment surgery. But if they don't have extrusion, you don't have to contain. Okay, this is clear, younger children. Older children, okay, more than 7 or 8-year age till 10-year age, if very young child who has come in stage 1A or 1B, age is more than 8 years, you will still observe. Don't jump to surgery. Some of these children, nowadays people do perfusion scans, and if perfusion scans shows that vascularity is compromised more than 50%, then people will go ahead and do core decompression or injection of bisphosphonates in these patients, but those are not literature proven procedures. So mostly they become conservative treatment. Moment you are in hearing B, an age less than 8 years, these are the children who are selected for a varus derotation osteotomy irrespective of the extrusion. Even if you don't have extrusion, but moment you have hearing B and collapse starting, you can do a femoral osteotomy. Age more than 8 years, extruded child, hearing C, these are not good enough for extrusion, and we, in earlier stages, we do a shelf procedure to cover them if we cannot contain. And very old children with deformed femoral head, there are various options if they are painful, and they include salvage procedures like osteochondroplasty, head reduction, or valgus osteotomy. Or if the head is very bad, very rarely we will excise this femoral head, or wait till they become around 20 or so and do a hip replacement. So those of you who want to just have a PDF of this talk, you can copy this QR code and download the PDF for a revision later on. And with this, if there are any questions, we can take. Otherwise, we can go for tea. Any questions from the students? Okay. So we can, yeah. Bhushan, please.
So, a child who's saying 8 years of age, borderline age, and you're seeing that he's in stage 1B, maybe 2A, but hearing A. By waiting, you realize that eventually the head, all Perthes cases are gonna go from stage 1 to stage 4, irrespective of the grade.
Right.
So by waiting, is there any chance that you could actually, reduce your chances of having a good outcome? Would this?
I'll answer that. It depends on where on the earth you are located, Manipal or Mumbai. Okay. So if you follow a thought process that at this stage, this child will 100% will extrude, and then your chance of getting sphericity by doing a VDRO later on is reduced, you will do an early VDRO. What we do in these patients is do a perfusion scan now. And if perfusion scan shows that the vascularity is affected less than 50%, then we will do a very close observation, which means I will not call that child after 3 months. Maybe I will call him after 6 weeks and do a range of movement and X-ray check again. But if the perfusion scan shows me that affection is more than 50%, then I will discuss with family and probably advise them to go for an early varus derotation osteotomy. For the advantage that when you do a VDRO, you are also introducing increased vascularization and skipping stages.
Thank you.
That's clear.